accurately in order to have long-term clinical success. How successful are we? I don't want to show you all these kind of studies. Yeah, I spare that you. So I just kind of summarized it in the upper row, which means that you have an annual failure rate of between 0.2 and 2.4. For those studies that have an observation time of at least 10 years. So we're looking at an average of about 2% actually of annual failure rate, which is quite good. I will show you later on how Ivoclar composites perform long term. So, but of course, at the end of the day, the patient has a significant role on how long the longevity is. For example, if the patient has a high caries risk, the failure rate can be double to a patient that has a low caries risk. Even if you do the same indication, the same filling, the same material, but those patients who have a high caries risk have a higher risk for failure. And of course, because it depends on the general caries risk, you know how the mouth is actually populated with cariogenic bacteria, but also about the oral hygiene that the patient is exercising. And age, bruxism also comes into play. But also here, look at this, operator-dependent outcomes. That's really true. Has been shown in a few studies that a patient with the same indication, which is treated by different dentists with different skill levels, they have a different outcome. So it really depends on the education of the dentist, how he performs the caries composite. Okay, so, but having said that, we want to have our restorations done in a high quality and high aesthetic way, but of course we would like to make this more efficient. If you think back on the around 58% of the restorations that we are doing, there is a big potential to optimize the efficiency in our workflow. And efficiency at the end of the day means more money, right? And so this is also a concern for the dentist. He needs to get his job quickly done without sacrificing the quality of the restoration. Of course, when it looks good, it's fine, okay, but you can overdo it also. In the posterior, the aesthetic demand, of course, is not the same like an anterior tissue. So I take much more time and sophistication for my anterior restorations compared to my posterior. What we do not want to have is, of course, a grayish-looking restoration, because then the patient will complain. And this is, of course, also related to the technology of the composite, which I will tell you about later on. However, throughout the studies, we have two top reasons for failure, always. It's actually fractures, the material, fractures or chips, and we have secondary or marginal caries. So these are the two most dominant reasons why restorations have to be replaced. But if you think of fractures, we talk about physical properties of the material. So if you have a very, very strong composite and you're not adequately light curing it, you will not have the full physical strength. And so the likelihood is also fracture. So that means actually that the light curing process is very, very important and getting even more important. And at the same time, this is one of the most underestimated factors by dentists worldwide. So I will dedicate a chapter for light curing or polymerization. So let's run quickly through a couple of topics here. You know about the isolation, of course. Ivoclar is providing two products for this. Actually, one for relative isolation and the other one for absolute or total isolation. So which is the product for total isolation that Ivoclar is offering? Sorry? You don't have to be shy. Huh? It's just, we're like a family, right? So we're just discussing things here, right? Of course, I would like to keep your mind a little bit awake so that you don't fall asleep. Yes, I heard some Optradam, right? So Optradam. If I would have asked for relative isolation, I think everybody would have immediately said Optragate, but with Optradam, you were not so sure, right? I mean, you, of course, you knew it because you knew it. But some other people were saying, what's that? It's because Optodam was really successful during pandemic because of the containment of the COVID-19 or because of SARS-CoV-2, and we could not keep up with the supply. Really, I mean, the demand was 700 times higher than we have expected. But now, I wouldn't say that the pandemic is over, but now, nobody wants to have it again. Yeah. But not because the product is not good, because dentists don't like to use a rubber dam. It's simple as that. So in the pandemic, they have been forced to use it, but now they're not forced to do it. So the strategy, and it was always like this when I did webinars about isolation techniques, I always talked about the Optrogate as well, because the Optrogate is our focus. Optrogate is our focus. Because the threshold for the dentist to use Optrogate is not so high compared to Optrodam. And then you can easily put in, or let's fly in Optrodam. Usually Optrodam plus. But otherwise, I think the focus is clearly on Optrogate. So, of course, we're no, it's not even substantiated that the total isolation is really better compared to relative isolation. Yeah? So there's not really strong scientific evidence behind this. So this study shows very, very low quality evidence. It may lead to a lower failure rate of restorations, but it's not really, let's say, strong evidence. Of course, there's a lot of advantages when you have a total isolation, especially with some patients which are very, very talkative, and every 5 minutes they need to rinse out. Oh, can I spit out? Can I rinse? No, can I rinse? Every 5 minutes. Guess how much time you lose? So when you have actually muted the patient with a rubber dam, then you can get your job done quicker. And that's exactly those patients that Gordon Christensen is referring to in a paper, and said he expecting time savings of up to 50% with a rubber dam. Yeah. So, and of course, the design of the Optodam is really different because it's really a 3-dimensional rubber dam, which is matching a 3-dimensional mouth compared to a 2-dimensional standard rubber dam. Yeah, because the design is really genius, I must say that, because you have these forces when you apply it. You have the tension towards the sulcus and the vestibular, the upper and lower, whereas with the standard rubber dam you have that force is going out of the mouth, and that's why you need some always clamps. With the Optodam you don't need a clamp for the anterior to the second premolar. You don't need a clamp only when you go to the posterior section of the molar. So and of course, during the pandemic, but you might still use this argument now, since the pandemic is still in full swing. You know, you have the inner ring, which is inside the vestibulum, and the outer ring is actually sealing the mouth 360 degrees. So you have that perioral seal. And when you have a conventional rubber dam, you have that on the frame, and you want to do an isolation on one side. It looks like this. If you have it isolated here, but from that side, everything can escape. All the viruses can escape from the other side. So, and this aspect is really very different. All right. Okay. Of course, you know these videos. You can find them on the Academy website. The step-by-step procedure. This one is the anterior, there's another one, posterior with a clamp. When you use a clamp, I would always recommend that you are pre-mounting the clamp first, and then that is easy to do. Yeah. As I said before, for the anterior you don't need any clamp. It's not necessary. You just need to go over the teeth with some floss over the contact point, and then you can actually using ligature here is an optional thing. You don't have to do that all the time. Right? It's really optional. Just in case you want to do a class 5, you would then further retract it, so you can do a class 5. However, you can see here there is no ligature. It's just how I applied it. You can still do like an inversion technique here. You can invert it. And this has been done here. So let's say most of the standard indication like class 3 and class 4, you actually don't need a ligature. Okay. And yeah, so of course the Ultragate is even more easier. Are you guys all using Ultragate, or you just tried it and said, okay, it looks nice, but actually it's not for me? You have some trouble using it? No? So when the dentist asks you, yeah, but it's very difficult, you know, here and here, I put it in the patient's mouth, and but then it's very difficult to get the reading actually behind the upper and lower lip. And what is your answer? There's one little thing to observe. Indonesia, welcome. The thing is, when you apply it on the patient's mouth, the mouth is open, right? On the left and right corner. What happens when you open the mouth? Tension. The lip is in tension. There is no space. So the patient, after you have done this, should close fingers, which actually was suggested anyway by the inventor. You grab the inner ring on the right and left side of the corner, and now the patient is slightly closing. And you can see now, almost with one hand, I can actually apply the So that is it's about 3 or 4 seconds application. So that's super quick. Not a problem. Good. So, and I think the secret of the success of Ultragate is it's such a versatile product. You can actually apply it in almost every situation in the clinic. For the stent, you can read it by yourself. Yeah. So prosthetics, general prosthetics, but also you can use it for scanning very nicely because it really retracts. Maybe there's one little thing. By the way, there's a product called Ultragate for scanning. Have you heard that? You know what's the difference? The name. Some very smart marketing trick. Yeah, you have a package, Ultragate for scanning. But there's no difference. Yeah? I don't know whose idea was that. Surprise that. It would be good to actually charge more for it because you can use it. Because those people who can afford a scanner, they can afford a more expensive option. Okay, well, what can happen sometimes, to be honest, when you do the buccal scan and you have contact with the scanning tip, sometimes you get I would say some friction, some grip. So you can use a little bit of Vaseline there, a little bit, so that it can slide a little, like a lubricant, yeah? Like Opera gel or something. I already submitted my patent on it. Okay, good. So about bonding procedures, did you know that we have, I would say we have the best bonding agent? Ivoclar. Is that too enthusiastic? Did I tell you that I'm only kind of biased, okay? Not totally biased. Why? I'm actually employed by Ivoclar, and of course my job is to motivate you and to instruct you, but I will not tell you any bullshit. Also not only not you, but also the clients not. Because I'm working independently in an independent dental office from Ivoclar. I'm the only dentist in Ivoclar that works externally. So I can use any kind of product in the clinic that I think is the best for my patients. Luckily, there's many Ivoclar products, but not only. So Ivoclar also has some products which I don't use in the clinic. That's okay. But anyway, the bonding agent is really good. I tell you about my history with bonding agents at Ivoclar. It was not always up, it was also going down, quality-wise. Really. I don't want to charge you with too much history, okay? Maybe just regarding generally about the bonding agents. I don't like to use this generation designation, like first to 8th, 7th, or 8th generation, because you really don't know what's the difference. So I would like to show it like this. So you can see the gold standard award, the first, let's say, bonding agents that really work, we actually started with the third generation. And these were the multi-bottle systems, and of course Ivoclar still has this system, it's called Syntac, with 3 bottles, yeah? So primer, adhesive, and heliobond. And so I've used this, when I was at university, I was confronted with my first bonding agent was this bonding agent, of course, because I'm already an old guy, okay? So, but since this is still quite popular in Switzerland, so even the guy I'm working with in the clinic, he used this for many years, and it was very difficult for me to introduce a one-step system like Adhesive Universal. Because he said, hey, this works best. And of course, there are numerous studies done at the University of Zurich and other universities worldwide, but also in Switzerland. But anyway, then of course, you could see phosphoric acid was used here on enamel predominantly, but you could also use it on dentin. Yeah, that was possible also here. Then everybody went to one-step total edge materials. So now everything in one bottle, but you had to edge enamel and dentin, both of them. When I was at the university, this was not yet existing. So when I would have edged the dentin, they would have kicked me out of the course because that was a big no-no to edge dentin. Then of course, because this was considered technique sensitive, so a lot of dentists had a lot of sensitivities with these kind of products. I'm talking about prime and bond, NT, all these products, right? So, of course, they also edged the dentin too long, and they did not scrub that in too long, so you had kind of a nano-leakage problem here, and also sensitivity issues. So the manufacturers then went to self-edge materials. Let's say Clearfield SE bond was the first one. Let's say the gold standard in self-edge materials was Clearfield SE bond. And Ivoclar had the Adhesive two-step material, like a primer and bond on top of it. So with these materials, okay, it's two-step and then it's one-step self-edge. But here, what about phosphoric acid? Because those years also dentists said, yeah, but you know, self-edge materials on enamel maybe are not so good. And actually they were not designed to be used in conjunction with phosphoric acid. And even some of the studies showed worse bond strength when you use phosphoric acid with them. And only now, when we talk about the one-step universal materials, these ones here, now you can use phosphoric acid again to your liking. If you want to use it on enamel or dentin, or whatever you like it. So these are the most flexible ones. And you can see here, all of them are bottle systems, except Ivoclar's. This one is a pen. Of course, it's also available in a bottle for those dentists who like to have a bottle. But I think the dentists that I know who tried the pen, they don't want to go back to a bottle. Okay, so nowadays everything is about one-step universal, and that's how we position ourselves. Yeah, I mean, since the good old days of Michael Ponopore, we know that the gold standard on enamel is always etching with phosphoric acid, and this is still valid today. So if you look at studies comparing using universal bonding agents with or without phosphoric acid, we see a difference. So you can see these guys have actually etched